afternoon from Bangkok, Thailand. Welcome to the 6th ADVA webinar entitled Predictors of Severe Dengue, What's New? My name is Thisyakorn. I am the Executive Director of Tropical Medicine Cluster, Chulalongkorn University, Bangkok, Thailand, as well as a steering committee member of ADVA, which stands for Asia Dengue Voice and Action. I will co-chair this session with Dr. Daniel Goh, who is an associate professor at Department of Paediatrics, Senior Consultant, Division of Paediatrics, Pulmonary and Sleep, Department of Paediatrics, who Teck Puat-National University Children's Medical Institute, National University Hospital, Singapore, as well as a steering committee member of ADVA, and most of all, he is my best friend. And briefly about ADVA, our co-conveners are the International Society for Neglected Tropical Diseases, Global Dengue Aedes Transmitted Disease Consortium, Foundation Maria, Southeast Asian Ministers of Education, Tropical Medicine and Public Health Network, and World Mosquito Program. This webinar is supported with unrestricted educational grants from Takeda Pharmaceutical Company Limited and Foundation Maria. May I now invite Dr. Daniel Goh to introduce our first speaker.
Thank you so much, Professor Usa, and good afternoon from Singapore. I'd like to welcome all our guests and participants from around the world. I understand we have over 567 registrants for today's webinar. It's such a pleasure and honor for me to co-chair this session with Professor Usa. As she said, we're old friends, that go back a way long way, really. So thank you very much for being here, and we shall get on with the first presentation. It is my great honor to introduce our first speaker for today's presentation, and she is Professor Somia Iqtadar from Lahore in Pakistan. Professor Iqtadar is an Associate Professor of Medicine at the King Edward Medical University. She is a Fellow of the College of Physicians and Surgeons in Pakistan and the Royal College of Physicians in London. Very heavily engaged in medical education, research, and clinical leadership, she's an avid member of many health and medical education committees and sits on many medical advisory boards as well. She's also the first General Secretary of the Pakistan Society of Internal Medicine and has published many articles in many journals with high impact factor. She is also involved in reviewing many national and international journals and is Associate Editor of the Journal of Pakistan Society of Internal Medicine and Frontiers of Tropical Medicine. She's also involved in many textbooks. Our very familiar Kumar and Clark textbook of medicine has written many chapters on dengue, Ebola, Congo, as well as guidelines on dengue, Congo influenza, and Ebola, as well as COVID-19. The list goes on really with her very impressive credentials. But very importantly, I think Professor Iqtadar is here to present to us a curious case of dengue, to introduce us to this whole very interesting and important topic of dengue disease with us. So Professor Iqtadar, please. Thank you.
Thank you very much, Professor Daniel, for your very generous introduction. Ladies and gentlemen, I will be discussing with you today a curious case of dengue infection, and there will be some interactive questions in between, I hope. So the story starts when a 34-year-old female comes to her general physician with a history of fever, body aches and pains, and severe headache for last 1 day. There's no vomiting, and previously she doesn't have any comorbidities. On examination, she has flushed skin. She is adequately hydrated. On examination of her vital statistics, the pulse is 86 per minute regular, blood pressure is 120/80 with no postural drop, and she is febrile with a temperature of 102 degrees Fahrenheit. There was no other abnormality detected on the general physical examination. So the GP ordered a CBC of this patient, which showed a hemoglobin of 12.2, white cell count of 4.2, and platelets of 128,000. Hematocrit was 39. She was sent home by the doctor. She was given paracetamol, and she was advised to drink a lot of fluids and have adequate rest. She came back after 2 days to the doctor again. She was still febrile. She had nausea and anorexia, and she looked ill. On examination, the pulse was 90 per minute and the blood pressure was 90 by 60 millimeters of mercury. Since she was ill looking and the blood pressure was on the lower side, the GP referred her to a hospital. In the hospital, her CBC was repeated. This time the HP was 12, white cell count, which was previously 4.2, had fallen to 3.8, and the platelet, which was 128,000 previously, was now 96,000. Hematocrit was nearly the same. It was 39 previously and 38.8 on this visit. She was admitted and her NS1 antigen was sent, and she was started on fluid therapy so to stabilize her hemodynamic status. So the first question from the audience is, do you think this is dengue infection? You can now vote by choosing yes or no, yes as A and no as B. Okay, so 95% of people think that this is dengue, but since the topic said that this is a curious case of dengue, so 5% still think that this is probably not dengue. Let's see what happens in the due course of when we discuss it. So yes, in my opinion, this looks like a dengue case because dengue is endemic in Pakistan. The patient has typical signs and symptoms of fever, body aches and pains and headache, no focus of infection, and there is a drop serially in white cell counts and the platelet count. So this makes you a probable diagnosis of dengue fever. Of course, we do not have a confirmatory test up till now. On the day 4, the patient CBC was repeated. This time her WBC has further fallen to 2.9. Hemoglobin was again the same, 12.2. Platelets were down a bit to 88,000. Hematocrit has risen a bit to 42. She has a pulse rate of 96 beats per minute. Blood pressure is 80 by 65, but she's afebrile now. In the evening, her CBC was repeated again. It was 3.4 this time. Hemoglobin was 12.4. Platelets have further fallen to 53,000. Hematocrit a bit risen to 46. Pulse is going up 108 beats per minute. Blood pressure is 80 by 60 with a pulse pressure of 20. And she is afebrile. So keeping in mind her vital statistics, her pulse was high, blood pressure was low, pulse pressure was narrow. She was given fluid and the rate of fluid was accelerated to keep up the blood pressure in the normal range. But the patient's condition deteriorated. She became restless and dyspneic. And this is the fluid which is given to the patient over the 24 hours period. This is the oral fluid in the orange, and blue shows you the IV fluid that she was receiving. On the day 5, when the patient was examined, she was conscious but drowsy. There was no focal neurological sign or neck stiffness. There was no obvious bleeding or purpuric rash. She had slight tenderness in her right hypochondrium and complained of mild abdominal pain. She was dyspneic. Her vitals showed a pulse rate of 110 beats per minute, blood pressure of 85 by 60. She was afebrile. Her respiratory rate was very high, 52 per minute, 52 breaths per minute, and oxygen saturation was 86%. And on auscultation of the chest, there were diminished breath sounds in both the lung bases. This is the ultrasonographic picture, which shows bilateral pleural effusion. There was mild ascites, there was pericholecystic edema, and thickened gallbladder wall, typical of dengue. So the next question is it DF, dengue fever, or dengue hemorrhagic fever? Can we have the poll? So DF or DHF? Okay. Can we have the results? Oh, so 30% think that this is simple dengue fever, while 70% people think that this is dengue hemorrhagic fever. And let me just clarify that in dengue hemorrhagic fever, there is plasma leakage, which is evident in this patient by rising hematocrit level, as well as ultrasonographic evidence of fluid collection in the pleural cavity, gallbladder wall edema, and pericholecystic fluid. So the clinical and lab evidence of plasma leakage and serial drop in the platelet count give us a diagnosis of dengue hemorrhagic fever. So now we move on. At this point in time, what is the phase of the dengue hemorrhagic fever? Is she incubating the virus still? Is she in the febrile phase? Is this the critical phase, or she has moved on to the recovery or convalescent phase? Okay, can we have the results, please? Okay, so the majority of the people think that she is in the critical phase, but few think that she's still in incubation phase, febrile phase, and few think that she's in recovery. But majority think she is in the critical phase, which is the correct answer, and I'm glad you can all pick that up. The critical phase is when there is evidence of plasma leakage. It can occur on any day from day 3 onwards. It is usually with the defervescence, that is settling of the fever, remains for 48 hours. And in this, there is plasma leakage due to a cytokine storm, which is inflammatory mediators release, which cause plasma leakage. So the day of illness is 5, there is narrow pulse pressure, there is a rise in packed cell volume, and there is clinical evidence of plasma leakage, which is confirmed by ultrasonography, which gives us the clue that this is a critical phase of dengue hemorrhagic fever. Now, what is the time of entry into the critical phase? Let's review. Sometimes on day 4, between the first and second CBC that we did, this is the time when the patient entered into the critical phase, because if you see, that was the transition to afebrile phase. There was a slight rising trend of WBC, reversal of neutrophil and lymphocytic ratio. There was a big drop in platelet count, and the packed cell volume was also rising, giving us a clue that this patient is going into plasma leakage. So this is the time of onset, and this is the time of ending. If we know the time of onset, we can calculate 48 hours, which is the approximate time when the critical phase will be over. So this is how you time the critical phase. If you know what is the time of onset, this is rising trend in WBC, reversal of lymphocytic and neutrophil ratio, 20% or more rise in the packed cell volume, and a big drop in the platelet count. This gives you a clue that the patient is entering into the critical phase. And from that, you count 24 to 48 hours. Mostly maximum time is usually 48 hours in which the patients, they start recovering. But on day 5, the patient's condition did not improve. She was given IPPV because she had a high respiratory rate and was not maintaining saturation. Her fluids, IV crystalloid and colloids, they were infused with careful monitoring of the vital signs. Next day, when she was examined, she was drowsy with no response to verbal commands. Expert opinion was taken and treatment offered until now, including the total amount of fluids given, was reviewed. So when they reviewed the chart of the patient and the fluid that she has been given in the last 48 hours was calculated, it was seen that she was given 1800 ml of normal saline. She was given 2 boluses of normal saline of 1000 ml each. Then she was given oral fluid in the form of water, some juice, 850 ml. So the first 24 hours, she received about 3,650 mils of fluid. And the urine output during this time was 650 mils, and she vomited once. In the next 24 hours, since her condition was not improving, her blood pressure was deteriorating, pulse was high, pulse pressure was narrow, she was kept on given fluid. She was also given dextran bolus twice to maintain the blood pressure, and she continued to take orally as well. And in the next 24 hours, she had taken 3,250 mils of fluid, and the urine output was 450 mils only. So when we calculated the whole amount of fluid that was infused to this patient and she had taken orally during the 48 hours period, it came out to be 3650 ml in the first 24 hours and 3250 ml in the next 24 hours. And so she was given about 7 liters, 6,900 ml of fluid in a 48 hours period of critical phase. And we all know from our guidelines that the maximum amount of fluid, which includes both oral and IV fluid, has to be carefully calculated according to the weight of the patient. And for any 50 kg adult or above, we just give maintenance plus 5% deficit, and it comes out to be 4,600 ml of fluid. So this has definitely exceeded the fluid quota which is allowed to be given in the dengue patient with critical phase. So why is this patient dyspneic? So it is not a respiratory virus. We all know that it mainly affects our cell count and there are body aches and pains, but generally there is no respiratory involvement in dengue. But in this patient, the patient is dyspneic with a respiratory rate of 52, not maintaining oxygen saturation, and she was on a positive pressure ventilation. The reason for the dyspnea in this patient was actually fluid overload. She had dyspnea, tachypnea, pleural effusion, low sats. There was exceeded fluid quota given in this patient in attempt to prevent the severe shock, and the colloid was not given appropriately because it was not judged that she is requiring too much fluid and it is not helping build her blood pressure. So probably the choice of fluid is not right and we need to switch the fluid to colloid therapy. So just to give you a quick exercise that how can we do that, if a patient has puffy eyelids, distended abdomen, tachypnea, dyspnea and orthopnea, and she's in respiratory distress, your hematocrit is low and your pulse is good volume and your urine output is adequate, always get an X-ray or an ultrasound of the patient, and you can give fluid therapy, dextran, along with a loop diuretic in this patient. So the next question is, the patient is also drowsy. Why is she drowsy? The drowsy is probably due to cerebral hypoxia from early shock. Respiratory rate was high, saturation was low, pulse pressure was low, so cerebral perfusion is low, which is leading to drowsiness in this patient. On day 7, she was examined again. On the clinical examination, she was pale, cold, restlessness. The patient had a tachycardia, pulse was feeble. She was afebrile, blood pressure was 90/70, and urine output was 0.4 mils per kg per hour. On the labs, CBC show rather a rise in the WBC of 14.8 with neutrophilic predominance. Hemoglobin was down to 9.1, packed cell volume dropped to 29.9, platelets were 87,000, electrolytes were okay, calcium was okay, blood urea and serum creatinine were marginally high, SGOT and SGPT, which are the liver enzymes, were high, serum albumin was low, and INR was 1.85. So what went wrong? So patient have somewhere bled because the hemoglobin is low, the packed cell volume is low, and the patient is not improving. So there is a possibility of a concealed hemorrhage, which is shown by a drop in PCV. Patient is hemodynamically unstable. Instead of giving crystalloid and colloid solution, you can see a rise in the WBC with neutrophilic predominance, and there is a sudden rise in the LFTs as well. The chest X-ray of the patient was taken, and you can see bilateral haziness in the fluids. So now the question was what to do. Obviously, we have to look for the concealed hemorrhage in this patient. So her pleural effusion was tapped, and we were surprised to see that it was a hemorrhagic pleural effusion. So whenever a patient comes to you who is in afebrile phase, restless, irritable with behavior changes, with the blood pressure is low, that is hemodynamically unstable, hematocrit is low and the urine output is low, you always think of a word bleeding, and in these patients, the patients can be given blood or packed cell volume depending upon the fluid quota that you have. So this patient was given packed red cells rather than blood because there was already fluid overload state, combined with fusamide because she was in overload. So how much blood is needed? We can calculate it by a simple formula. Baseline packed cell volume was 39% and the current packed cell volume is 29.9. So with the 20% increase in the critical phase, which we assume that there is a rise of 20% from the baseline, it would have been 39%, owing to plasma leakage and hemoconcentration. Therefore, the deficit we can calculate is 46.8 minus 29.9, which comes out to be 16.9. And we know that packed red cells at a dose of 5 ml raises the packed cell volume by about 5 points. So she needs a total of 15 ml per kg of the packed cell volume. On the day 9, her CBC was repeated. WBC was 11, neutrophil 78%, hemoglobin 11, packed cell volume 34. Platelets had risen, electrolytes were okay. Urea was 80, SGOT and SCPT were a bit high. Serum bilirubin was also a bit high. Patient was extubated. Pleural fluid culture and blood cultures were sent. So the lessons that we learned from this case was that fluid overload can occur unintentionally. We were trying to correct the hemodynamic status by giving on fluids, but there was a delay in changing to colloid and too much fluid was given in the critical phase. Patients should also be counseled about how much and what to drink, because oral fluid intake also contributes to the overload. And dextran is useful in fluid overloaded patients, and furosemide, which is a loop diuretic in small doses, is very useful if given along with the dextran. Whenever there is a refractory shock in the patient, we should always consider acidosis, bleeding, hypocalcemia, and hypoglycemia. In the critical phase, if the hematocrit drops with fluid therapy, but patient doesn't improve, always look for concealed hemorrhage. If drop in hematocrit is more than expected points, always look for concealed hemorrhage. And treat bleeding adequately with a blood transfusion or a packed cell volume, depending upon the fluid quota that is allowed to you. So just to summarize, whenever we see a dengue patient, the first question that we ask are, is it dengue or not? And for that, we have clinical signs and symptoms of dengue: fever, body aches and pains, retroorbital pain, myalgias, arthralgias, rash, or bleeding from any site. We have a supportive evidence from the CBC in the form of leukopenia and thrombocytopenia. The next question that we ask is it simple dengue fever or is there plasma leakage? If there is plasma leakage, this is DHF. If it is DHF, what is the phase of the illness? So in the critical phase, we find out the time of entry and predicted time of end. We aggressively monitor these patients, calculate their fluid quota, have a dynamic approach to fluid therapy, and then always update your diagnosis, whether it is DF or DHF or what is the grade of the DHF, and if there are any complications that needs to be addressed. Profound shock, prolonged shock, and fluid overload are commonly encountered in DHF patients, and they could be adequately addressed. And concealed hemorrhage should always be kept in mind if the patient's hematocrit is improving, but the patient is not clinically improved. Thank you very much.
Thank you, Dr. Somia. So we move to the next speaker, who is Dr. Chansuda Phubhakdi. Believe me, this is a very beautiful Thai name, so try to pronounce it. Dr. Chansuda Phubhakdi, who is an assistant professor at Division of Ambulatory Pediatrics, Faculty of Medicine, Chulalongkorn University, and King Chulalongkorn Memorial Hospital. Dr. Chansuda got her MD, Diploma of Pediatric Endocrinology and Adolescent Medicine from Chulalongkorn University, and got her master's degree in Child and Adolescent Mental Health from University College London, United Kingdom. And her main research works include general pediatrics, pediatrics endocrinology, and adolescent medicine. Today, she will present the latest information on cortisol, a new predictor of severe dengue. So Dr. Chansuda, please.
Good afternoon, everyone from Bangkok, and thank you very much, Dr. Usa, for a very nice introduction. I'm very honored to be here among you, a very strong network of the dengue. I hope that my expertise in endocrinology may be one of the jigsaw that can improve the treatment of the dengue.
Good afternoon, Chairman, Co-Chairman, and all participants. I am very honored to be invited as a speaker in ADVA meeting today. My topic is about serum cortisol as a new predictor of severe dengue. As we know, dengue infection is one of the mosquito-borne viral diseases that cause high morbidities and mortalities in many regions around the world, especially in Asian, African, and South American countries. Dengue infections can produce a wide range of clinical symptoms that vary from asymptomatic, acute illness, and severe illness. In the clinical practice, it is still challenging for physicians to predict the severity of dengue infection. WHO recommended warning signs to predict severe dengue infection, such as severe abdominal pain, persistent vomiting, rapid breathing, bleeding gums. However, patients with the warning signs may not develop severe dengue, while those without warning signs may later develop severe dengue infection. Regarding cortisol, it It is one of the steroid hormones that mediated by hypothalamic pituitary and adrenal axis. Normally, serum cortisol levels range between 5 to 24 micrograms per dl, with significant variability depending on the time of the day. The physiological diurnal cortisol rhythm is shown in this figure. Peak of cortisol levels would be measured during 8 o'clock in the morning. Cortisol is often called stress hormone. We know that serum cortisol levels will be increased related to the degree of physical or psychological stresses. During physiological stress, for example, hypotension or severe infection, the hypothalamic pituitary adrenal axis is activated and diurnal variation is lost. This figure represents endocrine response to stress. When neurotransmitters increase, they will activate hypothalamus to increase corticotropin-releasing hormone or CRH and arginine vasopressin or AVP. Then activate adenocortical hormone to adrenal cortex to increase glucocorticoids. Moreover, neurotransmitter also activate adrenal medulla through the sympathoadrenal axis to secrete more catecholamines. Increasing level of cortisol and releasing vasopressin help body to maintain blood perfusion to the vital organs during intense stresses. Nowadays, there were studies demonstrated that serum cortisol levels can represent the severe stresses. For example, the study among pediatric patients admitted in ICU with a variety of serious illnesses. The graph shows that increasing of cortisol levels is related to poorer prognosis. As this figure showed the correlation between cortisol levels and PRISM 3 score, which one of the most recent scoring system of pediatric mortality. This study also showed the ROC curve of cortisol as a predictor of mortality. You can see that serum cortisol level at the cutoff of 30 micrograms per dl. Total serum cortisol has sensitivity 90% and specificity 60% to predict the mortality. Regarding cortisol level after other viral infection, another study showed the serum cortisol level surge after influenza B virus infection compared with the control. You can see this bar is higher than the control. The second picture showed the correlation between serum cortisol and the chemokine CCL20 after infected with the influenza B virus. The study from UK represented that higher cortisol level in the early day of admission were associated with a higher mortality among COVID-19 patients. Cortisol levels was also used as a biomarker to predict severity in serious illnesses. However, it is still unclear about cortisol response during dengue infection. There were only few previous studies regarding cortisol during dengue infection. The study in 1995 showed that cases with dengue hemorrhagic fever had significantly higher serum cortisol level than in the control. The mean of cortisol in dengue hemorrhagic fever were higher than dengue fever groups, but not statistically significant. In cases of dengue hemorrhagic fever, mean serum cortisol during the acute stage was found to be significant twofold higher than convalescent stage. This slide shows another study by Professor Sutipong from our institute, Chulalongkorn University, Bangkok, Thailand. The results showed that serum cortisols were high during the febrile state and shock state, and then turned down during the convalescent state. However, this study could not show the difference of the cortisol level between dengue fever and dengue hemorrhagic fever. This one is the most recent study in adult patients in Thailand. The dot plot showed that the mean of the cortisol among patients with dengue hemorrhagic fever was higher than those of dengue fever. there was no significant difference between cortisol levels among dengue hemorrhagic fever and dengue fever. By the evidence from the previous studies, we still cannot see the whole picture of the dynamic of cortisol responses after dengue infection because first, the previous studies recruit small sample size. Second, they also use the old version of the WHO criteria to categorize the severity of dengue that could not cover adequate complication entities. And the last point is that previous studies used the different timing of the blood sample collection. Therefore, we still have some questions regarding the dynamic of the cortisol responses after dengue infection. Can we use the cortisol as a predictor of severe dengue? Or is there any treatment role of the corticosteroid in severe dengue? Along with the dengue cohort study that we have collaboration with the Ban Pong and Pothoram Hospital in Ratchaburi province. We conducted the study about the dynamic of cortisol during dengue infection. We hypothesized that early cortisol response may predict the severity of dengue infection and can also potentially serve as the biomarkers of severe dengue. So our study aimed to first to investigate the pattern of cortisol response at the different time points in patients with severe and non-severe dengue. And second, we would like to evaluate the possibility of using cortisol at the day of the hospital admission as a clinical biomarker to predict severe dengue. This slide shows the timeline that we collected, the clinical data and blood samples from patients diagnosed with severe with dengue infection. We collected the clinical data, related lab, and also serum cortisol at the day of the hospital admission. We call it first day and the day 3 or the third day and day of effervescence and day of discharge from the hospital. We conducted this study in 2018. Most of participants were teenagers and young adults. The median age was 17 years old. At first, we recruited the clinical diagnosed dengue infection patients. We had 376 participants. We confirmed dengue infection by serology tests, including IgM antibody and S1 antigen, and detection of genomic dengue RNA using RT-PCR. After exclusion, we had 265 participants. We follow up the clinical symptoms and categorize them into severe and non-severe dengue, along with the WHO criteria 2009. There were 26 participants, or approximately 10% of severe dengue. This figure shows the serum cortisol levels. Cortisol levels of non-severe dengue presented with the green color, and severe dengue groups are presented in the red colors. Serum cortisol level in participants with severe dengue infection were significantly higher than those of non-severe dengue infection in the first day and the third day of hospitalization. This figure shows the dynamic of the mean cortisol changes during admission. The pattern of the cortisol dynamic were similar in both groups. The cortisol level were highest on the first day and the third day, and then decreased on the day of effervescence and the day of discharge from the hospital. However, the mean of cortisol of severe dengue group were higher than non-severe dengue group in every time point. This table shows the sensitivities, specificities, positive predictive values, and negative predictive values of cortisol concentration levels at the first day of the admission. We determined the most appropriate cutoff of cortisol concentration at the first day of visit can predict dengue severity by ROC analysis. The best cutoff value for diagnosis severe dengue was 18.2 microgram per DL with the AUC 0.62 with the 95% CI at 0.51 and 0.99% 0.74. The sensitivity 0.65 and specificity 0.62, and PPV positive predictive value at 0.16 and NPV negative predictive value at 0.94. This slide shows the AUC of serum cortisol cutoff to predict the severe dengue. The green line shows the serum cortisol cutoff at 18.2 microgram per DL. Based on the regression analysis, we combine the first day of the cortisol level with the other clinical data to get a better prediction for severe dengue. The AUC increased to 0.74 when we combine cortisol level with the persistent vomiting and the day of fever. For the discussion, our data show the dynamic of cortisol, which turns into maximum level during the early time point of admission. And this cortisol concentration had been rising in response to the stress, then turning down when disease progressed to the defervescent day and hospital discharge day. Patients with severe dengue infection were more likely to have higher cortisol levels than non-severe dengue patients to hospital admission. The levels of cortisol in dengue infection were comparable with other viral infection, but obviously lower than the bacterial infection. We postulated the mechanism that viral may express some amino acid sequence that has molecular mimics with the endogenous ACTH in the host and subsequently produce antibody against the amino acid sequence, causing low ACTH and relatively adenocortical insufficiency. Or it may have the direct invasion to adrenal gland. Cortisol levels more than 18.2 may be used as the predictors of severe dengue. Moreover, its predictive values seem to be increased when combined with the clinical model. So we propose that the strength of this study were a prospective design and a large sample size, and we also used the 2009 revised dengue severity classification of the WHO. The limitation of this study was that we have low number of cases with organ impairment such as acute kidney injury or acute liver injury. So the further study are needed to determine whether our results are valid for these types of severe dengue or not. We suggest that the further research should focus on the evaluation of cortisol as a biomarker of severe dengue in clinical practice. Also, the clinical trial of steroid therapy, especially during the febrile stage, is in selected cases should be investigated. Finally, I would like to thank you, Professor Dr. Thisyakorn and Associate Professor Nattachai Srisawat, Professor Vishit Supon-Sinchai, and Professor Dr. Chulongkorn for their valuable advice and our staff for their hard work running this study. Thank you for your attention.
Thank you very much, Dr. Chansuda, for sharing the important findings, which may lead to a better understanding of the severe dengue. So we'll move to the last speaker, who will be introduced by Dr. Daniel Goh.
Yes, thank you very much.
Go on.
Thank you very much, Dr. Chansuda, for a very nice presentation. And it's my pleasure to introduce our third speaker, Professor Nattachai Srisawat. Professor Nattachai is an adult nephrologist and intensivist, the director of the Excellence Center for Critical Care Nephrology at the King Chulalongkorn Memorial Hospital, the Thai Red Cross, in the Chulalongkorn University in Bangkok. He was a CRISMA Research and Clinical Research Fellow in Critical Care Medicine in the Department of Critical Care Medicine at University of Pittsburgh School of Medicine in Pennsylvania, USA. His main research focus is on acute kidney injury epidemiology and also novel biomarkers of acute kidney injury in tropical infections causing acute kidney injury as well. His research interests include also critical care nephrology, renal replacement therapy in the intensive care unit, aseptic acute kidney injury, and urinary and plasma biomarkers. And Professor Nattachai is going to share with us very interesting presentation on the role of circulating microRNAs as a predictor of the as a biomarkers for predicting severe dengue disease. Thank you, Professor Nattachai.
Thank you, Professor Daniel, for a kind introduction. So, and thank you, the ADVA committee, for inviting me to share our recent study on circulating microRNA as a biomarker for predicting severe dengue infections. So, everyone knows that dengue is a global health problem, around 400 million new cases per year, and that also accounts for one of the leading cause for morbidity and mortality, not only in the children, but now it's become also the problem for our young adolescents and young adult patients. As you may know that already from the previous two speakers, that from our current dengue classification that we use, the WHO 2009, and we know about the dengue or warning signs. We also know that this warning sign sometimes has some quite a low sensitivity, and also some of the important parameters, including GI bleeding or leukocytosis, do not account in this warning sign. So as a clinician and a researcher, we're still looking for the better classification. And also in regarding to the pathogenesis of severe dengue infections, the host response is one of the key factors. This is including the viral factor, especially the amount of the virus or the viremia, and also the genotype and the serotype is quite important. In terms of the host response, also we know that the age, especially in the elderly cases, quite an important determinant of the outcome of the patient. And also the comorbidity that is quite common in the adult cases, also one of the major determinant of the outcomes. Not only these two, but also the previous the immune factor also quite play an important role, including the primary or secondary infection, that also very important. And also that already emphasized by Professor Somia, that the clinical management also very, very important to mitigate all the inflammation that happen during severe dengue infections. So in summary, from our current situation that we have the biomarker or the marker for predict dengue infection, recently we have created the Thai dengue score by using the previous clinical data from Professor Usa and Professor Jun that has been extensively collected during the last 20 years. And this dengue score can be one of the potential predictor of severe dengue infection. We also have the dengue factor, include genotype and viral load, high viral load as a marker. Cytokine, in some cytokine also can be a specific predictor. That also including the cholesterol, like a low total cholesterol and low LDL, might be another interesting marker, and also the cortisol level that already presented by Professor Chansuda. Lactate also has been studied in the past by the Thai study group, especially from tropical medicine, faculty of tropical medicine, Mahidol University, that already mentioned about this one. Endothelial activation, especially like a kinase, that has been extensive study also from Singapore groups, also show some potential predictor of severe dengue infections. Our group interested in one of important molecule we call the microRNA. The microRNA is the one of the non-coding RNA that has play a role in terms of the regulating gene expression. It's not translate into the RNA, but it's quite an important marker to control the transcription. And we know that each microRNA could control 100 of the microRNA. On the other hand, each microRNA can also regulate 100 also of the mRNA. And we in this study, we are interested in the circulating microRNA that can potentially detected from our body fluid, including in the plasma. And we believe that this microRNA also has a role in terms of controlling the messenger RNA expression, and especially in the messenger RNA that related to the inflammatory process. That bring into our study that we aim to find out the early prognostic marker of severe dengue infection, and this. So we aim to identify the potential circulating microRNA as a biomarker for severe dengue. We use the same cohort as Professor Chansuda just mentioned. Is a multi-center prospective observational study from King Chulalongkorn Memorial Hospital, Bangkok, Thailand, a hospital from Ratchaburi province. We collect the sample over 1.5 years. As you can see that our population study, including a wide range of the age group, including the children and also the up to the elderly age group. And we confirm all the cases by using a standard positive IgM or NS1 antigen, and also so we classify them by using WHO 2009. We follow the patients until the day of discharge, and actually we collect the sample in many time points. But in this study, we plan to test the microRNA expression on the first day of the hospital admission, because we believe that this is maybe one of the day that is really important day that we can if we can predict the future severe dengue infection or the leakage phenomenon. So in this is our study design. The discovery phase, again we are using the sample from day 1 to find out the potential microRNA expression. In this study, we have in the discovery phase, we stratify the patient into severe and non-severe around 50-50. And then we extract the microRNA, and we approach by the way to detect microRNA by using the nanostring encounter system. After we find out some potential microRNA, we test them in our validation cohort. Again, we use the sample from day 1 of admission, and right now we increase the sample size up to around 130. Around 15% is a severe case classified by WHO 2009. After that, we will using the real-time PCR to quantify amount of a microRNA and see that they can still differentiate between severe and non-severe dengue infections. This is the microRNA technique that we use. We use a nanostring technique that we target at least 800 human microRNA in the same time. This technique contrasts to the previous technique that using a direct detection because we use the specific probe to the target microRNA, and then we use the expression probe or to express the specific probe that already target, and then we verify and expression the quantify by using the encounter system. This process is quite a fast process. The hand-on time is less than an hour, and the time results come back in less than 1 day. As you can see from our patient characteristic, this table shows the data from the discovery set and the validation set. Only some, this is the data also from mostly from day 1. As you can see that only few clinical parameters that can discriminate between severe and non-severe dengue infection. But and also one of the potential clinical is the respiratory rate that a bit faster in severe case, and also if then the IgM positive more common in the non-severe case. In terms of patient characteristic from a warning sign, as you can see that the alteration of consciousness might be an important warning sign, and liver enlargement also important, and that shows some significant difference in the validation cohort in severe case. And this is the result of in the discovery phase of microRNA expression. We classify the patient into severe dengue and non-severe. And in this way, we have the 6 potential candidate microRNA expression as shown in this slide. And after we discover some potential candidate microRNA that express more in severe case, and this our marker expressed at the first day of admission. So this is quite important because this is the day that the patient still look okay, not turn into the critical phase, as mentioned from the first case report. In the validation cohort, we have, like I mentioned, that we classify them into severe and non-severe case, and all the 6 potential microRNA still has a strong difference level, higher level in the severe case comparing to the non-severe case in every microRNA, in every circulating microRNA. When we classify them into dengue infection with warning sign, and also severe dengue infection, again you can see the stepwise relative expression of these 6 microRNA, and still show a positive significantly difference as a stepwise level. When we look into the relationship of this circulating microRNA and clinical parameters, there are some these microRNA show positive correlation with the neutrophil level, creatinine, and the liver function test, and also show negative correlate with the platelet count or thrombocytopenia. These AUCRC curves show that the microRNA 57.4 and 12.46 show a very high the AUCRC curve at the level of 0.83, comparing between severe and non-severe case. And when we stratify the biomarkers by day off before fever coming down or before day fever recent, this might be another way to show how this parameter, the biomarker, can predict the severe case. When the day close to the day of fever down or the fever recent, show a better predictor. Is quite but still show a very strong AUCRC number. So this is quite good that if we can predict the critical phase at least 48 hours before the event, that should be another way that we can prevent the complications. When we look into the cut point and the sensitivity, specificity, PPV, and NP, this is the proposed cut point. But as you can see that this kind of the biomarkers quite have a strong negative predictive value, which means if biomarkers less than the certain cut point level that we shown, is quite be safe for our patients to be discharged to home or avoid unnecessary admission. So this might be another potential application for the future role of biomarker in severe dengue infections. And this kind of the high NPV show across the age group, the children and adult. And when we perform another analysis by the multivariate regression analysis, the microRNA 574 still show a strong predictor with the p-value less than 0.001. Association between microRNA and outcome most of the marker or microRNA that we shown has a correlation with the plasma leakage phenomenon, which is one of the important phenomenon of severe case, and also some of them show correlation with the good predictor for mucosal bleeding. So in summary, we have identified more than 30 microRNA that differential expression between two study groups, and we select for top 6 candidate microRNA for predict severe dengue infection, and confirm our finding in our validation cohort. MicroRNA 1246 and 574 show the very high AUC-ROC curve at the 0.83 with a high NPV and sensitivity. However, we still looking for when we because it's already shown a very high AUC-ROC curve, when we combine all the microRNA together, do not show much improvement. One of the important finding is our sample that we test the sample at the time of admission. That means this marker quite be a potential marker to predict the future severe dengue infections. MicroRNA 1246 has been shown in the past in some small study that upregulate in dengue infection. This is the study that we have summarized. But still clearly unknown about the role of this microRNA in severe dengue infections. Another one, 574, also shows some expression in regulate the toll-like receptor 9. And also microRNA 1303 also shows some, that is a microRNA that control one of the important receptor that we call the toll-like receptor 4. And this microRNA is one of the microRNA that regulate this transcriptor. So in the future, I propose that after the validation discovery and the validation phase, we may try to apply this microRNA in the application phase more, and try to apply them into potential using in our clinical practice. And this one, maybe we need to have more larger sample size to apply them. So in conclusion, in this study, we show the circulating microRNA, especially 574 and microRNA 1246, can be a promising biomarker, and we should study them more in terms of the characteristic biology and the messenger RNA that they control, and try to translate them into using them in our clinical practice in the near future. Thank you very much.
Thank you very much, Dr. Nattachai, for very nice information. So Dr. Daniel Go, shall we start with the Q&A session now?
Yes, thank you very much. And thank you to all our speakers. And we shall open the session for Q&As, and we'll invite all our speakers, our panelists, including our very dear Professor Lulu Bravo, to join us on a panel to address any questions. You may type in your questions at the Q&A portal, or even at the chat section, or you could raise your hands and ask your questions as well. So we'd like to invite our audience to, hello, Professor Lulu, and to ask the questions. And thank you for the few questions that were already typed into the Q&A portal. And thank you, Professor Iqtadar, for addressing them. But there is a question on the Q&A which say from Elisa, that, thank you for the great lecture. And which one do you think is superior, dextran or gelafundin in shock for dengue? Which do you prefer? Yeah, maybe Professor Iqtadar would like to address that.
Okay, so we generally use dextran 40 in our country for dengue shock syndrome. We have more experience, and it has more volume expansion as compared to gelafundin. And it lasts for a longer duration of time, 6 to 12 hours, as compared to gelafundin. And it also improves the microcirculatory flow by decreasing the viscosity of the blood by hemodilation and also by inhibiting the erythrocyte aggregation. But we have to be careful when the patient's renal profile is deranged, because we know that dextran can be problematic with kidney function because it causes the renal tubular plugging. So in renal compromised patients, dextran is not used. And also it inhibits with the platelet adherence and decreases the factor VIII and increases the chances of bleeding if given in the large doses. So we need to be careful because it can increase the chances of bleeding and there could be coagulation abnormalities. And it can interfere with the blood grouping and cross-matching as well. So we take a sample prior to that. But in some of the studies, if you go to the literature, the best colloid has been declared as dextran. But there are some studies which show gelafundin and hetastarch as non-inferiority trials to dextran. So, but in our country, we only have dextran available and we use dextran, and that is why we chose dextran for this patient.
Thank you very much, Professor Iqtadar, for a very comprehensive.
May I, Dr. Daniel, go?
Yes, yes, please.
Yes. You know, in our country, since we have several colloid, and then the intensivists try to stop us from using dextran because they are afraid of something that Dr. Somia has already said about the disturbance of the coagulation. So I would like to hear from Dr. Nattachai, what do you think? Because you are one of the intensivists. So what else you would like to use besides the normal saline?
Thank you, Professor Usa. I just would like to mention about the role of the colloid. As you may know that maybe one of the safest colloid, as we know, is the albumin. And in the guideline of we call the sepsis cerebral sepsis campaign guideline, they also recommend to use the albumin as the adjunctive or the subsequent amount of the fluid resuscitation, especially when you give fair amount of the crystalloid. One of the best or potential to use the colloid is to improve or to fasten the resuscitation process that already been shown in the BIO study in New England Journal of Medicine 7 years ago. But again, I would like to emphasize that the colloid still cannot show any survival benefit over the crystalloid. But the only benefit of the colloid is they can fasten the process of the resuscitation and make the patient to avoid unnecessary the vasopressor.
Thank you very much.
But in Thailand, we try to avoid dextran, as already mentioned by Professor Somia, that it may hurt to the kidney. That's why if you're giving fair amount, like more than a liter, maybe from my opinion, I still think the albumin might be a bit safer.
Thank you very much for your inputs. Yes, shall we address the next question? There's a question on portal asking, it's probably directed to Professor Nattachai. Are there any strong correlations of microRNA in the pathogenesis of dengue infection? And are these microRNAs specific only for dengue infections?
I think this is a very important question. We still don't know much about the microRNA and the dengue. And our study might be one of the first few study. But from our finding, it shows that this microRNA already shown some strong correlation with the high AUC-ROC curve at 0.84, 0.83. But however, we still need to study more in terms of the correlation of this microRNA to severe dengue infections.
May I, Dr. Daniel?
Yes, please.
Yes,
Professor.
Our title today is the predictor of severe dengue. What's new? We already heard what's new. So I would like to know what's next. Dr. Nattachai, can you tell us what's next? What are you going to do? Don't worry, you have a lot of friends. They may go on and then work more rapid than you. You don't mind, don't you?
No, I think this is quite very nice seminar that we can provide and review many new findings to our colleagues, not only me but also by Professor Somia and Professor Chansuda. I think the next step that we may need to maybe more study in terms of clinical trial, because as you may know that in more than 50 years that we know about this virus, we still don't have any effective treatment. But I think our finding might be the open gate for the new clinical trials that we try to mitigate all this kind of the information in the near future.
Yeah. Dr. Daniel, if you don't mind, may I repeat the same question to Dr. Chansuda? Yeah, so what's next? So you already show your study about the cortisol. That's quite interesting. So what would be the next thing that you are going to do?
Yeah, as Dr. Nattachai mentioned, we gonna try the clinical trial that may change the treatment of the dengue, because we know that the cortisol is highest at the first, at the early day of the admission. So it may be like a COVID-19 model that cortisol or corticosteroid may have the benefit to treat, to prevent the inflammatory markers. We may have to give it early, because the previous studies usually give the corticosteroid in the critical stage that could not help the people. So I think we should go to this way.
So you mean that we need to go with the right amount and right timing, is that right?
Yeah.
Because if you go to the previous study, you can see that they use the steroid in some dengue patients without any successful. Some use it at the end stage, which is useless.
And also serum cortisol may guide our decision to use corticosteroid or not in terms of we can predict. For example, if the cortisol is high, we may predict for the severe. We may select the more proper case to use the corticosteroid.
Dr. Somia, you have anything to say about the corticosteroid in your management of dengue patients?
We generally do not use corticosteroids in management of dengue patients, because in a small set of studies in which we did try the corticosteroids, but they were of no help in improving the patients. So generally, we do not use corticosteroids. Corticosteroids can be used for other indications if, in addition, there is sepsis or septic shock we sometimes give, but generally we do not give for dengue shock syndrome. Although it's very interesting to study that why they do not work when we have cytokine storm in COVID and the steroids have become the first choice, and we have a similar cytokine storm in dengue, but the steroids are not working there. I think this is also an area of research that we should look into, maybe in a smaller dose of steroids, or sometimes or maybe the cortisol, which Dr. Chansuda just mentioned, because there is a cortisol, so maybe we can. So I think we should all collaborate on a research which should be not related to only one area like Bangkok or Singapore, but the whole region, where we can have a pool of different types of patients and then try our hypothesis. What is next in dengue should be the vaccine, because we should now move on. If we can have a vaccine for COVID in a period of 1 year, we've been trying for so many decades now for dengue, and still we're not able to get any effective vaccine. Professor Lulu, I see on the screen, and she has some experience in Philippines regarding the dengue vaccine program, which was not a success over there, but we are really looking forward to the newer candidates of vaccines which are coming up, and I hope that either there is an effective vaccine for dengue, or we come up with a pan-serotype antiviral drug for dengue, because the dengue burden is increasing day by day. And just now we had a huge epidemic in Pakistan this year. On top of COVID, we had an epidemic of dengue, which was very, very challenging for the healthcare professionals, because they have we were not out of the COVID wave when there was an epidemic of dengue, and we were really challenged by the two disasters coming together.
Okay. So please, if you can go with the World Society of Pediatric Infectious Disease meeting which will happen during February 22nd to the 24th, although you are internist, because Dr. Nattachai will present there. Dengue and COVID, double trouble. Would you like to listen to that one? I think it's very interesting because, they may share some common antigen. We don't know what happened because many people also say the same thing to other arbovirus that we have in this region, Zika, chikungunya, and Japanese encephalitis. So you go and listen to Dr. Nattachai. Dr. Nattachai already promoted for you. Okay.
Thank you so much, Professor.
That's a scary question. Dr. Daniel, would you like to go to that one for Dr. Somia? Quite scary.
It is.
Yeah.
No, I'd like to hear from Professor Lulu, actually. What do you think, after hearing all these presentations, what in your mind is next? I think that's a very important point to discuss as well. Professor Lulu.
Thank you, Daniel, and thank you, USA, marvelous moderators. I salute all of you and the speakers. Wow, you did very, very informative lectures, and predictors of severe dengue is what we need in order to manage them well, right? But in the meantime, I support Professor Somia when she says that, yes, we do have to even predict before it happens. And in fact, prevention is always the best way to really kind of control and reduce the burden that dengue has. Because when dengue strikes, when there are outbreaks, we know the healthcare system could also be threatened, just like when COVID struck and dengue with it. Wow, our healthcare system could actually be threatened, right? Because like in the Philippines, in 2019, we did have 400,000 cases over a 2-month period. That was really resulting in 1,000 deaths. So prevention is really at the core. And I'm interested, Professor Nattachai, that honest to goodness, that was my first lesson in microRNA. That was something exciting for me. And whether or not you can probably determine some biomarkers that could tell you, even before you have dengue, whether these microRNAs can actually help us maybe prevent future dengue incidents. That would be exciting for us. And even cortisol levels, if you are compromised, Dr. Chansuda, if you are compromised, if you have, hormonal imbalances, would that also lead you to severe dengue in the future so that we can sort of balance these hormones? I mean, these are very important features that dengue we need to really look into pathogenesis prevention. These are exciting times, even if we are still in a pandemic. But we know the pandemic will end very soon. Over to you, and thank you very much.
Thank you, Lulu. Always injecting a lot of energy to the discussion. Yes, Professor Usa, you were saying? You're muted. Yes.
But Dr. Somia, I don't really like to ask this question, but I have to because they address to Dr. Somia only. The person said, should we aspirate and drain the concealed hemorrhage? Or else we may end up with a tamponade. So what do you think?
Yeah, I already answered in the chat box, but just for the character, we generally do not aspirate the effusions or the collections because they resolve on themselves. Especially if they are mild, you just leave them and in a couple of days they are gone and they are reabsorbed by themselves. But if that is causing a respiratory compromise and the patient is deteriorating, like in this case, in which patient was constantly going into respiratory compromise and we had to put her on the ventilator, and the effusion was increasing in size rather than resolving. And then on top of that, there was a drop in the hemoglobin and the hematocrit saying that there is concealed hemorrhage somewhere, and we could not find at the usual sites. We know that the commonest bleeding sites are from the GI, and we get a bleeding from gastrointestinal tract, but the NG was there. There was no melena in this patient, and there was some concealed hemorrhage, and we had to look for that. And the patient had a respiratory rate gone up to 52, put on ventilator. So we Out of curiosity, we tried to, aspirate this patient, and then there was a gush of blood coming out, so we had to aspirate it. There have been reports in the literature about hemothorax being the cause of respiratory compromise in dengue, and the hemothorax can be life-threatening. So if it is leading to tamponade, it should be aspirated.
Okay, Dr. Somia, there is ongoing question. The person asked why the pleural effusion need to be aspirated.
So as I told you, it's generally not needed to be aspirated, and it is resolved on its own.
That's true. No, and then the person asked why. Why?
Because
you said generally not, but sometimes you need to do it. Is that right, Dr. Somia? Why? They asked why.
Yeah, you have to take an expert opinion. If you see that the patient is not improving and the effusion is gradually increasing in size, causing deterioration in the patient's condition, sometimes you have to aspirate it, but that has to be in a critical setting under the supervision of a senior person or an anesthetist, and by giving a platelet transfusion sometimes to the patient so that there is no risk of bleeding to that patient. So generally, as a rule, we do not aspirate infusion, and they are resolved by on itself, but in very few circumstances. That is why it was a curious case of dengue and not a usual case of dengue.
I'm very glad to hear that. And you need to have a very proper blood bank that have every blood component, or else you might come across the problem, a big problem. I don't know, I can ask the experience from our only intensivist here. And Dr. Nattachai, what do you think? The aspiration of pleural effusion or aspiration and drain of the concealed hemorrhage? I don't know whether we have done that or not.
Normally we try to avoid that, Professor Usa, except that effusion compromise like ventilation or oxygenation of the patients, and because we try to avoid further complication.
Okay, thank you. So you answer the same thing. So yeah, I'm not amazed. You are both internists. You have the same answers. That's great. So Dr. Daniel Go, would you like to go for another question?
Yeah, I think they've answered most of the questions now. Anybody else has any other questions you'd like to pose? The panel is at your disposal now. If not, maybe I'll ask Dr. Chansuda a question. I've seen other publications where they talk about cortisol levels in severe dengue versus non-severe dengue. And some have reported that in severe dengue, there's actually lower cortisol levels than in non-severe dengue. So how do you reconcile some of these different observations? Is it a matter of timing or the stage of the disease, or how do you reconcile this?
I think that the result it may different be from the different time to collect the sample, but in our study we try to collect from the first day of admission, because the patient will the clinical patient will turning down, because we also want to know that is that can be a predictor for severe or not. So the study that you mentioned may collect the sample in the different time with our study.
Actually, Dr. Chansuda, you still have a sample in sequence, is that right? So you can always go back if you would like to do further study, is that right?
Yeah, it's very important, and we may analyze in a different way to see the correlation with the day of fever as well. So we may have the different results.
Okay, so this is just the first step, because you believe that the first day of admission may be the day that you would like to be able to tell which way that the patient will go. Is that right?
Yeah.
I hope you can do that, and then probably in the future we may come up with a better management. But Dr. Daniel Go, so please, we still have about 5 minutes.
Yes, thank you. Yeah, and Professor Nattachai, I was just reading an article from a paper from Singapore looking at the microRNAs in dengue as well. And I think there are many papers that talk about different expressions, different microRNAs in different studies. And do you think that we could in the next phase or ultimately come up with a panel of selected microRNAs, or do you think this would be location-specific or individual-specific RNAs, microRNAs actually? Is there going to be a generalizable selection of microRNAs that we can actually apply in the assessment of dengue disease or any other infections as well? What are your thoughts on that?
Thank you, Professor Khoo. And I agree that yes, in the future, we may have, as already mentioned in our study, that we show some specific, like a 6 microRNA that show the high level of discrimination between severe and non-severe. So, but in my opinion, I don't think every microRNA expression the same thing. And also in dengue, we already show from around 800 microRNA that we try to test it. Only 6 that show some positive, strong positive correlation. And I think with our current technology, with the high throughput technology, this allows us to identify the best candidate microRNA.
Thank you very much. Professor Lulu, do you have any other comments or any questions?
Really to congratulate the whole team, I think Professor Somia and Professor Nattachai. It's very exciting, this way forward for dengue. I think we should all really give our full attention to not just predicting which dengue will be severe, but also predicting how we can prevent, severe dengue this time. And even the mere fact that it is a global threat today. Thank you very much.
Thank you. Yeah, we have one more question on the Q&A portal from Florentina. Thank you for this question. It's probably directed to Professor Somia, and we welcome inputs from other panelists as well. Are there clinical signs that will guide clinicians when to get cortisol level, and how often do we monitor? Actually, maybe Professor Chansuda first. Yeah. Cortisol level. What are the clinical signs will guide clinicians when to get cortisol levels, and how often do we monitor? Because we hear from Professor Chansuda and then the rest of the panelists later.
I think when the patient was admitted to the hospital, because the clinical might get worse, because we don't need to know in the asymptomatic patient or only the mild patient. So I think that's the very most appropriate time to do. But we will study more about the clinical model to use the model, or we may develop the score to predict the severe dengue as a more effectiveness, or increase the predictive values. In the next time, we may use our model in the clinical practice, and then we collect the data and see even can we develop the dengue score, something like that.
Thank you very much. Thank you. Professor Somia, how do you think this could be applied in clinical practice?
I don't think that there are any clinical signs which points to a level of high cortisol in the body, which we can, and not to my knowledge. I think this is because it is in the preliminary state of investigation whether cortisol can be a predictor of severe disease. So the serial monitoring of cortisol right at the beginning, then at the start of the critical phase, and then in the recovery phase, and then comparing the different levels, what might give us an idea. I was just going through the literature. I don't remember. I remember vividly, but in children it was actually reversed. There was low cortisol level seen in severe dengue as compared to simple dengue fever in children, pediatric population. So I don't know how this will be translated in the future, and if we can use cortisol level, because that we all know that cortisol is a stress hormone and it is released in acute stressful conditions. But how far we can apply it clinically, and if there are any clinical features which suggest us to get the cortisol levels can help us. We know the clinical signs of severe dengue, that if the patient has a persistent abdominal pain or vomiting, or the red flags, the patient is not improving, despite settling of the fever or the tachycardia is persisting, or there's a narrowing of pulse pressure, or there is liver involvement. These are all clinical signs predicting the severe dengue. But I don't know if cortisol can well correlate with all these signs. Maybe a questionnaire and then comparing it with the cortisol levels might give us a clue of if any of these signs have a correlation with the cortisol levels.
Right, thank you very much. I think it's about time. I'll hand it back to Professor Usa to sum up and close.
Okay, thank you, Dr. Daniel Goh. I think we all of us enjoyed very much this afternoon. And on behalf of the Asia Dengue Voice and Action, I would like to thank Dr. Daniel Goh, who co-chaired this session, Professor Lulu Bravo for her input, and all speakers for their excellent presentations. And thanks also go to Takeda Pharmaceutical Company Limited and Foundation Mary for their unrestricted educational grants, and all delegates for their presence and inputs. Most of all, to the Secretariat team led by Dr. Francis Wang, Mr. Wilson Thiel, and Mr. Joseph Leung, who has been working very hard for a successful webinar. So I think we'll see each other next June at the next ADVA activities, Asia Dengue Summit in Singapore, and Dr. Daniel Goh will be the host. Many thanks and goodbye.
Thank you very much and goodbye.